The abdominal wall is subdivided into the anterior wall, the right and left lateral walls, and the posterior wall. These walls are musculo-aponeurotic, meaning they are composed of muscles and fascial layers, except for the posterior wall, which is also made up by the lumbar vertebral column. This musculo-aponeurotic wall functions to enclose and protect the abdominal viscera, stabilize and contribute to movements of the trunk, and also increase the intra-abdominal pressure which is needed during urination, defecation, vomiting, and assisting in childbirth. Now, the anterior and lateral abdominal walls are collectively known as the anterolateral abdominal wall, mainly because the boundary between the two is not distinct. So the anterolateral abdominal wall extends from the thoracic cage down to the pelvis. More specifically, it's bounded superiorly by the cartilages of the 7th through 10th ribs as well as the xiphoid process, and inferiorly by the inguinal ligament and superior margins of the anterolateral aspects of the pelvic girdle. The anterolateral wall is composed of many different layers. There are 12 of them in total. The most superficial layer is the skin, which covers a superficial fatty layer of subcutaneous tissue, or fat, known as camper fascia, which is a major site of fat storage. Deep to the camper fascia, there is a membranous layer of subcutaneous tissue known as scarpa fascia, which continues inferiorly with the superficial perineal fascia, or Colles fascia. And deep to the superficial fascial layers, there are 3 muscle layers, each covered in a layer of a deep fascia, so 6 layers in total. So, right after scarpa fascia, there's the superficial investing fascia, followed by the most superficial muscular layer, the external oblique muscle. Then comes the intermediate investing fascia and the internal oblique muscle. And finally, there are the deep investing fascia and the transversus abdominis muscle. Deep to the transversus abdominis is the transversalis fascia. And finally, for our 2 deepest layers, there is a thin layer of extraperitoneal fat which is just above the parietal peritoneum, which is the deepest layer of the abdominal wall and lines the abdominal cavity. So just to recap, let's take a quick break and see if you can recall the layers of the anterolateral abdominal wall. Now let's talk muscles. The external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle are considered the flat abdominal muscles, and the fibers of each have varying orientations. All 3 of these abdominal muscles continue anteriorly and medially as aponeuroses. Aponeuroses are simply flat sheets of fibrous tissue that anchor muscles to bone, deep fascia, or other muscles. The aponeuroses from the left and right flat abdominal muscles fuse in the midline to form the linea alba, which is Latin for white line, and runs from the xiphoid process to the pubic symphysis. The external oblique is the largest and most superficial of the anterolateral abdominal muscles. It originates at the external surfaces of the 5th through 12th ribs and inserts on the linea alba, pubic tubercle, and the anterior half of the iliac crest. The posterior fibers of the external oblique are nearly vertical as they travel distally toward the iliac crest. The more anterior fibers, however, fan out medially, making most of the muscular fibers run inferomedially. To remember this, the orientation of the external oblique muscle fibers are in the same direction as your fingers are when your hands are in your pocket. These muscle fibers eventually become aponeurotic around the mid-clavicular line, forming a sheet of tendinous fibers that cross at the linea alba. The inferior margin of the aponeurotic portion also forms the inguinal ligament connecting the anterior superior iliac spine to the pubic tubercle. The muscular portion of the external oblique contributes primarily to the lateral abdominal wall, and the anterior aponeurotic portion contributes to the anterior abdominal wall. The external oblique is innervated by the thoracoabdominal nerves, which are derived from the anterior rami of the T7 to T11 spinal nerves, as well as by the subcostal nerve, which is the anterior ramus of T12. The external oblique flexes and rotates the trunk, like when you're doing those Russian twists at the gym. It also compresses and supports the organs within the abdominal cavity, particularly during expiration. Deep to the external oblique muscles are the internal oblique muscles. Most of their fibers run perpendicularly to the external oblique muscle fibers, so they head infrolaterally. Try giving yourself a hug and placing your hands on your hips. The internal oblique fibers would run in the same direction as your fingers. The posterior portion of the internal oblique muscles originate from the broad connective tissue attached to the spine known as the thoracolumbar fascia, and also originates from the anterior 2/3 of the iliac crest and tissue deep to the lateral third of the inguinal ligament. The internal oblique then inserts at the inferior border of the 10th through 12th ribs posteriorly and the linea alba anteriorly. It is innervated by the thoracoabdominal nerves, which again are derived from the anterior rami of the T7 to T11 and also by the subcostal nerve and branches of L1 anterior ramus. Similar to the external oblique, the internal oblique muscle compresses and supports abdominal viscera and also helps to flex and rotate the trunk. More specifically, since many of their fibers are actually continuous at the linea alba, the right external oblique and the contralateral left internal oblique would work together to bring the right shoulder towards the left hip. The deepest and final layer of the flat abdominal muscles is the transversus abdominis. Living up to its name, its fibers run transversely, except for the inferior fibers which run parallel to the internal oblique. This muscle originates from a number of structures, including the internal surface of the 7th to 12th costal cartilages, the thoracolumbar fascia, iliac crest, and connective tissue deep to the lateral third of the inguinal ligament. Along with the external and internal obliques, it inserts at the linea alba, as well as the pubic crest. It also has the same innervation as the internal oblique and the thoracoabdominal nerves, subcostal nerve, and the nerves from the L1 anterior ramus. And similar to both oblique muscles, the transversus abdominis helps to compress the abdominal contents in order to increase intra-abdominal pressure, which is helpful during forced expiration, defecation, and labor. Unlike the obliques, though, it doesn't play a role in trunk movement. Besides the flat abdominal muscles, there are also vertical abdominal muscles, namely the rectus abdominis and pyramidalis muscle. The rectus abdominis is a set of vertically oriented paired muscles that lies right at the midline of the anterior abdominal wall and originates at the pubic symphysis and pubic crests and inserts at the xiphoid process and 5th through 7th costal cartilages. It is innervated by the anterior rami of T7 to T12 via the thoracoabdominal and subcostal nerves. The rectus abdominis is a powerful flexor of the trunk, so you can thank this muscle when you do your crunches. It also helps stabilize the tilt of the pelvis, and just like the other abdominal muscles, it compresses the abdominal viscera. The pair of rectus abdominis muscles is separated in the midline by the linea alba, which is a fibrous band composed of interweaving aponeuroses from the flat abdominal muscles. The rectus abdominis is mostly enclosed by the rectus sheath, where the anterior layer of the rectus sheath anchors the rectus muscle transversely by tendinous intersections, which create the bulges seen in people with well-defined abs, or a six-pack. The second vertical abdominal muscle is the pyramidalis muscle, which is a smaller, triangular, or pyramidal-shaped muscle. It lies anterior to the lower portion of the rectus abdominis and originates on the anterior surface of the pubis and inserts at the linea alba. Interestingly, up to 20% of people don't have a pyramidalis muscle, but luckily it is not a critical organ, considering its only function is to tense the linea alba. Now, the fibrous rectus sheath is a strong, incomplete aponeurotic covering of the pyramidalis muscle and the rectus abdominis muscle. It also contains the superior epigastric and inferior epigastric arteries, which are an important blood supply for the abdominal wall, as well as other veins, lymphatic vessels, and nerves. The overall function of the rectus sheath is to protect the structures contained within it. The rectus sheath itself is formed from interweaving of the flat abdominal muscles aponeuroses with one another. Now, the rectus sheath is divided into an anterior and posterior layer. However, the rectus sheath is not uniform throughout, so its composition is different in three main areas: above the costal margin, below the costal margin to the arcuate line, and then below the arcuate line to the pubic crest. So, the anterior layer of the rectus sheath above the costal margin consists only of the external oblique aponeurosis. It doesn't contain a posterior layer, and therefore the rectus abdominis lies directly on the thoracic wall. Between the costal margin to just below the umbilicus, the rectus sheath contains an anterior and posterior layer. The internal oblique aponeurosis splits into two layers, or laminae, at the lateral border of the rectus abdominis. The anterior lamina of the internal oblique aponeurosis passes anterior to the muscle and merges with the aponeurosis of the external oblique to form the anterior layer of the rectus sheath. The posterior lamina of the internal oblique aponeurosis passes posterior to the rectus abdominis and merges with the aponeurosis of the transversus abdominis to form the posterior layer of the rectus sheath. Finally, the lower portion of the rectus sheath begins approximately 1/3 of the distance from the umbilicus, or belly button, to the pubic crest. Here, the anterior layer of the rectus sheath is composed of the aponeuroses from all three flat muscles, as the aponeuroses making up the posterior rectus sheath pass anterior to the rectus abdominis, leaving only the transversalis fascia posteriorly. The transition between the thin transversalis fascia covering the inferior quarter of the rectus abdominis and the posterior layer of the rectus sheath covering the superior 3/4 is demarcated by an anatomical landmark known as the arcuate line. Now, can you identify the 3 flat abdominal muscles and the 2 vertical muscles on this image? Next, let's take a look at the internal surface of the anterolateral abdominal wall. The internal surface of the anterolateral abdominal wall is covered with parietal peritoneum. The part of the peritoneum directly below the umbilicus folds into 5 distinct umbilical peritoneal folds, 1 in the median plane and 2 on each side. The fold in the median plane is the median umbilical fold, which extends from the apex of the bladder to the umbilicus and covers a structure known as the median umbilical ligament, which is a remnant of the fetal urachus that originally served to connect the fetal bladder to the umbilicus. Moving laterally on each side of the median umbilical fold, there are the left and right medial umbilical folds covering the medial umbilical ligaments, which are remnants of the fetal umbilical arteries. To remember the median from the medial umbilical folds, think that median means in the middle, so it's the one on the midline. Also, the word medial has an L in it, which should prompt you to remember that it is lateral to the median fold. Moving even further laterally on each side, we come to the last pair of umbilical folds, known as the lateral umbilical folds. These lateral folds are the only ones that don't cover an embryologic remnant, and instead cover the inferior epigastric arteries. So now let's have a look at the sensory innervation of the abdominal wall. The skin and muscles of the anterolateral abdominal wall are mainly innervated by the thoracoabdominal nerves, the subcostal nerve, and the iliohypogastric and ilioinguinal. So first, as we've mentioned, the thoracoabdominal nerves are derived from the anterior rami of the T7 to T11 spinal nerves. Specifically, these nerves are actually the continuation of the lower intercostal nerves distal to the costal margin, where they run in the neurovascular plane between the internal oblique and transversus abdominis. Some of the thoracoabdominal nerves then branch into the lateral and anterior cutaneous branches, which emerge anywhere between T7 and T11. More specifically, the lateral cutaneous branches enter the subcutaneous tissue along the anterior axillary line, in comparison to the anterior cutaneous branches, which enter the subcutaneous tissue closer to the median plane, or midline of the body. The anterior cutaneous branches of T7 to T9 innervate the skin above the umbilicus. T10 supplies the skin at the level of the umbilicus, and T11 innervates a portion of the skin below the umbilicus. Next, the subcostal nerve is the anterior ramus of the T12 spinal nerve, and as the name suggests, it runs along the lower border of the 12th rib before entering the neurovascular plane of the abdominal wall. Similar to the thoracoabdominal nerves, the subcostal nerves also divide into anterior and lateral cutaneous branches, which provide sensory innervation to the skin between the umbilicus and iliac crest. The anterior ramus of the L1 spinal nerve divides into the iliohypogastric and ilioinguinal nerves. The iliohypogastric nerve innervates the internal oblique and transversus abdominis muscles and supplies sensory innervation to the skin overlying the iliac crest, upper inguinal, and hypogastric regions. In contrast, the ilioinguinal nerve supplies the inferior portion of the internal oblique and transversus abdominis and provides sensory innervation of the skin overlying the lower inguinal region, mons pubis, anterior scrotum or labia majora, and medial thigh. The dermatome map matches the distribution of these nerves, where each dermatome begins posteriorly where the spinal nerve exits the vertebral column and generally follows in the direction of the ribs as it wraps around the lateral portion of the trunk to the anterior abdomen. Remember, the nerves, as well as the blood vessels, can generally be found running in the neurovascular plane of the anterolateral abdominal wall, which is the space between the internal oblique and transversus abdominis muscle. Next up, there's the arterial supply of the abdominal wall. First off, there's the superior epigastric artery, which is a continuation of the internal thoracic artery. It descends inferiorly and goes through the rectus sheath deep to the rectus abdominis into the posterior layer and provides blood supply to the superior portion of the rectus abdominis. At the level of the umbilicus, the superior epigastric artery anastomoses with the inferior epigastric artery, which originates from the external iliac artery superior to the inguinal ligament and descends upwards in the transversalis fascia to enter the rectus sheath below the arcuate line. Like the superior epigastric artery, the musculophrenic artery is a terminal branch of the internal thoracic artery. It descends along the costal margin or the rib cage and provides blood supply to the hypochondriac region and anterolateral parts of the diaphragm. The rest of the abdominal wall is supplied by smaller branches. The deep circumflex iliac artery originates from the external iliac artery and provides blood supply to the deep abdominal wall of the inguinal region. The superficial circumflex iliac artery arises from the femoral artery and provides blood to the superficial inguinal region. Another artery that originates from the femoral artery is the superficial epigastric artery, which provides blood to the superficial abdominal wall of the pubic and inferior umbilical regions. Finally, there are the 10th and 11th posterior intercostal arteries, as well as the subcostal arteries, which originate from the aorta and provide blood supply to the lateral region of the anterolateral abdominal wall. And where there are arteries, you know it, there must be veins. So, the skin over the anterolateral abdominal wall is drained by a superficial subcutaneous venous plexus into the internal thoracic vein supromedially, the lateral thoracic vein superolaterally, and inferiorly it drains to the superficial and inferior epigastric veins, which eventually carry the blood to the femoral vein and external iliac vein. Cutaneous veins around the umbilicus anastomose with the para-umbilical veins, which are tributaries of the hepatic portal vein. A superficial anastomotic channel may exist laterally called the thoracoepigastric vein, running between the superficial epigastric vein and the lateral thoracic vein. The deep veins of the anterolateral abdominal wall accompany the arteries, bearing the same names. A deeper, more medial anastomosis can also exist between the inferior epigastric vein, which drains into the external iliac vein, and the superior epigastric vein, which drains into the internal thoracic vein. Finally, regarding lymphatic drainage, the superficial lymph vessels accompanying subcutaneous veins and those found above the umbilicus mainly drain into the axillary lymph nodes and peristernal lymph nodes. Those found inferior to the umbilicus will drain into the superficial inguinal lymph nodes. The deep lymphatic vessels accompany deep veins of the abdominal wall and drain into the external and common iliac lymph nodes, or the right and left lumbar lymph nodes. Alright, as a quick recap, the anterolateral abdominal wall is the area between the thoracic wall and pelvis and is composed of multiple layers of muscles and fascia. The flat abdominal muscles include the external oblique, internal oblique, and transversus abdominis. These muscles eventually become aponeurotic, and these aponeuroses go on to create the rectus sheath. The anterior layer of the rectus sheath is mainly formed by the external oblique and anterior lamina of the internal oblique, whereas the posterior layer is formed by the transversus abdominis and posterior lamina of the internal oblique. A third of the way from the umbilicus to the pubic crest, this posterior layer passes anterior to the rectus abdominis, ending the posterior rectus sheath and leaving only the thin transversalis fascia posteriorly. This transition is demarcated by the arcuate line. This rectus sheath incompletely envelops the vertical abdominal muscles, which are the rectus abdominis and pyramidalis. On the internal surface of the abdominal wall, there are 5 umbilical folds. A median umbilical fold, and on either side of it there are 2 medial and 2 lateral umbilical folds. Between the internal oblique and the transversus abdominis, there's the neurovascular plane that innervates the anterolateral abdominal wall. The skin and muscles of the anterolateral abdominal wall are innervated by the thoracoabdominal nerves from thoracic nerves T7 to T11, the subcostal nerves at T12, and the iliohypogastric and ilioinguinal nerves from lumbar nerve L1. Some of the major arteries that supply the anterior abdominal wall include the superior and inferior epigastric artery, as well as the musculophrenic artery. Superficial lymph vessels above the umbilicus primarily drain towards the axillary lymph nodes, whereas below the umbilicus they drain towards the superficial inguinal lymph nodes. Deep lymph vessels drain into the external iliac lymph nodes and common iliac lymph nodes, as well as the lumbar lymph nodes.
The diaphragm is a dome-shaped sheet of skeletal muscle that divides the thoracic cavity from the abdominal cavity. That may sound simple, but in fact, the diaphragm is so much more than just a sheet of muscle. In fact, every breath you take is thanks to your diaphragm. Okay, so let's begin by looking at the general structure of the diaphragm. It curves superiorly into right and left domes. It has a mobile central portion known as the central tendon, and a peripheral muscular portion that is fixed to the bones, cartilages, and ligaments of the thoracic cage. The periphery of the diaphragm can be divided into 3 parts depending on its specific attachment points. The sternal part attaches to the posterior aspect of the xiphoid process. The costal part attaches to the internal surfaces of the 7th to the 12th ribs and their costal cartilages, while the lumbar part attaches to the medial and lateral arcuate ligaments, the L1 to L3 vertebral bodies, and the intervertebral discs in between. Now, the diaphragm is the chief muscle for inspiration, meaning that when it contracts, it helps us breathe in. During contraction, the central portion of the diaphragm depresses, increasing the volume of the thoracic cavity, which in turn increases the volume in the lungs. This makes the intrapulmonary pressure fall below the atmospheric pressure, creating a partial vacuum that allows fresh air to be sucked in. On the other hand, expiration is largely passive, meaning the diaphragm relaxes and rises, which decreases the volume of the thoracic cavity and subsequently increases the intrapulmonary pressure to be above the atmospheric pressure, forcing the air in the lungs to be expelled out. The diaphragm also helps with circulation. During contraction, the increased intra-abdominal pressure and decreased intrathoracic pressure helps venous return of blood towards the heart through the inferior vena cava. In order to properly perform its functions, the diaphragm is attached to surrounding structures by various ligaments and muscular crura. First up, the medial and lateral arcuate ligaments. The medial arcuate ligament is a thickening of fascia that covers the psoas major muscle, which then attaches to the lumbar vertebral bodies and the transverse process of L1. Whereas the lateral arcuate ligament covers the quadratus lumborum muscles and attaches from the transverse process of L1 to the 12th rib. Next are the crura, which are musculotendinous bands that attach to the anterior portion of the vertebral bodies. The right crus is larger and longer, and it typically arises from the L1 to L3 vertebrae, while the shorter left crus typically arises from the L1 to L2 vertebrae. Lastly, the fibrous median arcuate ligament is formed where the right and left crura join in the midline approximately at the level of the T12 vertebra. The diaphragm also has three major apertures, which give passage to the structures running between the thoracic and the abdominal cavities. These include the caval opening, which is located in the central tendon of the diaphragm, slightly to the right of the median plane. The caval opening is located at the level of the T8 vertebra. It serves as a passageway for the inferior vena cava, plus the terminal branches of the right phrenic nerve. Next is the esophageal hiatus, which is located in the right crus of the diaphragm at the level of the T10 vertebra. The esophageal hiatus transmits the esophagus, the esophageal branches of the left gastric vessels, and both the anterior and posterior vagal trunks. The third major opening is the aortic hiatus, which is actually posterior to the diaphragm, located at the level of the T12 vertebra. It is located between the left and right crura, posterior to the median arcuate ligament. The aortic hiatus allows passage for the descending aorta, the azygous and hemiazygous veins, and the thoracic duct. Alright, now for a quick break. Can you recall the diaphragmatic apertures at the level of T8, T10, and T12? Now, let's talk about blood supply. The superior surface of the diaphragm is supplied by the pericardiacophrenic artery and musculophrenic artery, which are branches of the internal thoracic artery, and the superior phrenic arteries, which are branches of the thoracic aorta just superior to the aortic hiatus. Its inferior surface is supplied by the inferior phrenic arteries, which arise from the abdominal aorta. Venous drainage of the superior surface is ensured by the musculophrenic veins and pericardiacophrenic veins, which empty into the internal thoracic veins, and the superior phrenic vein, which empties into the inferior vena cava. Intuitively, the inferior surface of the diaphragm is drained by the right and left inferior phrenic veins. The motor innervation of the diaphragm comes entirely from the right and left phrenic nerves, which originate from the anterior rami of the C3 to C5 spinal nerves. Remember this rhyme: C3, 4, 5 keep the diaphragm alive. Sensory innervation for the central part of the diaphragm is also ensured by the phrenic nerves, while the peripheral part is innervated by the T5 to T11 intercostal nerves and subcostal nerves. The lymphatic drainage of the superior surface of the diaphragm is to the anterior diaphragmatic lymph nodes and posterior diaphragmatic lymph nodes, which then drain into the peristernal, posterior mediastinal, and phrenic lymph nodes. The lymphatic drainage of the inferior surface of the diaphragm is to the anterior diaphragmatic, phrenic, and superior lumbar lymph nodes. Alright, as a quick recap. The diaphragm is a dome-shaped skeletal muscle found between the thoracic and the abdominal cavities, which serves as the chief muscle of inspiration. It also allows passage of important structures between the thorax and the abdomen through its three apertures, which are the caval opening, the esophageal hiatus, and the aortic hiatus. Its superior surface is supplied by the superior phrenic arteries, which are branches of the thoracic aorta, and the pericardiacophrenic and musculophrenic arteries, which are branches of the internal thoracic artery. The inferior surface of the diaphragm receives blood supply from the inferior phrenic arteries, which are branches of the abdominal aorta. Venous drainage of the superior surface is ensured by the musculophrenic and pericardiacophrenic veins, which empty into the internal thoracic veins, and the superior phrenic vein that empties into the inferior vena cava. Venous drainage of the inferior surface is ensured by the right and left inferior phrenic veins. Finally, its motor innervation is provided by the right and left phrenic nerves.
When you eat, food travels over 15 feet before leaving your body. But before it leaves, it has two final stops, the rectum and the anal canal. Let's explore these gastrointestinal organs of the pelvis and discuss the process of defecation and the structures involved. The rectum is the terminal chamber of the large intestine that temporarily stores feces before defecation. The rectum joins with the sigmoid colon at the level of S3, forming the recto-sigmoid junction. Then, the rectum courses below in the pelvic cavity, reaching a point anterior and inferior to the tip of the coccyx. Here, the rectum pierces the levator ani muscle to join with the anal canal, forming the anorectal junction. Let's think of the pelvis like a bowl. The levator ani muscle acts as the bottom of the bowl to support the structures within the pelvis, especially the rectum. Another structure that supports the rectum is the anococcygeal ligament, which forms a fibrous ridge from the anal canal to the coccyx, acting as an anchor. The relations of the rectum to the surrounding structures differs between biologically male and biologically female individuals. In males, the rectum lies behind the fundus of the urinary bladder, the seminal vesicles, the left and right ductus deferens, and the prostate gland. In females, the rectum lies behind the lower end of the uterus and the vagina. Rectum is a Latin word that means straight, but this is a bit misleading because a human rectum actually has many flexures. These flexures include the sacral, the anorectal, and the superior, inferior, and intermediate lateral flexures. The sacral flexure follows the curve of the sacrum and the coccyx, forming an antero-posterior curve with an anterior concavity. Next is the anorectal flexure, which is a sharp posterior-inferior angle at the anorectal junction. This flexure is maintained by a sling-like muscle, puborectalis, which is part of the levator ani muscle group. When contracted, the puborectalis muscle pulls on the anorectal flexure, preventing feces from entering the anal canal, which maintains fecal continence by keeping the feces stored in the rectum. Now, let's move to the anterior view of the rectum, which shows three sharp curves called the lateral flexures. These include the superior and inferior lateral flexure, which lie on the left side, and the intermediate lateral flexure, which lies on the right side of the rectum. These lateral flexures match three internal folds of the rectum, called the superior, middle, and inferior transverse rectal folds. Just inferior to the inferior transverse rectal fold, forming the last part of the rectum, is the ampulla of the rectum. This pouch is supported by the levator ani muscles and by a ligament that extends from the tip of the coccyx to the external anal sphincter, called the anococcygeal ligament. The ampulla of the rectum expands to store feces before defecation, which also helps maintain fecal continence. Okay, now let's look at the relationship between the rectum and the peritoneum. To do that, let's slice the rectum into thirds. In the upper third, the peritoneum covers the anterior and lateral surfaces of the rectum. The lateral extension of the peritoneum forms a fossa on each side of the rectum, called the pararectal fossa, which allows the rectum to expand when it fills with feces. Then, the peritoneum continues to cover only the anterior surface of the middle third of the rectum. From here, the course of the peritoneum is a bit different in males and females. In males, the peritoneum reflects from the middle third of the rectum to the posterior surface of the bladder, forming the rectovesical pouch. In females, the peritoneum reflects from the middle third of the rectum to the posterior surface of the vagina and the uterus, forming the rectouterine pouch. In both males and females, the lower third is without peritoneal cover and is considered subperitoneal. The blood supply of the rectum comes from superior, middle, and inferior rectal arteries. The superior rectal artery is a lower continuation of the inferior mesenteric artery, which arises directly from the abdominal aorta. This artery supplies the superior part of the rectum. Next are the left and right middle rectal arteries, which arise from the anterior division of the internal iliac arteries to supply the middle and lower parts of the rectum. Finally, the left and right inferior rectal arteries arise from the internal pudendal arteries, which are branches of the anterior division of the internal iliac arteries. These arteries supply the anorectal junction and the anal canal. Venous blood from the rectum drains into the three main tributaries, the superior, the middle, and the inferior rectal veins. The superior rectal vein drains into the inferior mesenteric vein, which is part of the portal circulation. The middle rectal vein drains blood from the ampulla of the rectum into the internal iliac veins, which are part of the systemic venous system. Finally, the inferior rectal veins drain into the internal pudendal veins, which drain into the internal iliac veins, which, again, are part of the systemic venous system. These three sets of rectal veins all anastomose together within the walls of the rectum and anus, forming a connection between the portal and systemic systems. This type of special connection is called a portosystemic anastomosis. Finally, the motor innervation of the rectum is supplied by the sympathetic and parasympathetic divisions of the autonomic nervous system. Let's start with the sympathetic fibers, which arise from the lumbar spinal cord and pass through the lumbar splanchnic nerves and the superior and inferior hypogastric plexuses to reach the rectum. Next are the parasympathetic fibers, which arise from S2 to S4 levels of the spinal cord and pass through the pelvic splanchnic nerves and the inferior hypogastric plexus to reach the rectum. Finally, the rectum lies below the pelvic pain line, meaning that visceral afferent fibers from the rectum follow the parasympathetic fibers to the S2 through S4 sensory ganglia. Okay, now let's take a deep breath and have a quick quiz. Can you name this junction? All right, but can you name this part of the rectum? Let's move a little farther down and talk about the anal canal, which is a small tube that forms the last part of the gastrointestinal tract. The anal canal begins at the anorectal junction and descends postero-inferiorly to end at the anus, which is the external opening of the gastrointestinal tract. Typically, the anal canal is collapsed and expands as feces pass through it during defecation. Similar to the urinary bladder, the anal canal has internal and external sphincters, which are circular muscles that control defecation. Let's start with the internal anal sphincter, which is an involuntary muscle surrounding the anal canal. Typically, this sphincter contracts to prevent the leakage of feces or gas, and relaxes as the rectal ampulla fills with feces. The external anal sphincter is a voluntary muscle that surrounds the anal canal and has deep, superficial, and subcutaneous parts. This muscle blends superiorly with the puborectalis muscle and attaches posteriorly to the coccyx by the anococcygeal ligament. Now, let's look inside the anal canal. The upper half of the anal canal has longitudinal ridges, called the anal columns, which contain the terminal branches of the superior rectal artery and vein. At the upper ends of these columns, the wide rectal ampulla narrows to join the anal canal, forming the anal-rectal junction. Also, the lower ends of adjacent columns are joined by folds called anal valves. These valves have a small space above them called the anal sinuses. These sinuses make defecation a little bit easier by adding mucus to the feces. The lower borders of the anal sinuses and valves form an irregular line called the pectinate line. This line divides the anal canal into an upper and lower part, which differ in embryonic origin. The upper part is derived from the embryonic hindgut, while the lower part is derived from the embryonic proctodeum. For this reason, the pectinate line is an important feature to help distinguish the blood supply, nerve supply, and lymphatic drainage patterns in the upper and lower parts of the anal canal. First, let's discuss some general patterns, and then we'll talk about some exceptions. Above the pectinate line, arterial supply comes from the superior rectal artery, which is a continuation of the inferior mesenteric artery. The internal rectal venous plexus drains above the pectinate line into the superior rectal vein, which continues to become the inferior mesenteric vein, which is part of the portal system. The lymphatic vessels drain into the internal iliac lymph nodes. Lastly, the nerve supply above the pectinate line is visceral innervation from the inferior hypogastric plexus, providing sympathetic, parasympathetic, and visceral afferent fibers. First are the sympathetic fibers, which stimulate and maintain the contraction of the internal anal sphincter. Next are the parasympathetic fibers, which relax the internal anal sphincter and initiate peristaltic movement of the bowel during defecation. Finally, the afferent fibers from the upper part of the anal canal are visceral, making it sensitive to stretch only. The upper part of the anal canal also lies below the pelvic pain line, which means the visceral afferent fibers travel with the parasympathetic fibers to the spinal sensory ganglia at the level of S2 to S4. Below the pectinate line, the arterial supply comes from the two inferior rectal arteries, which are branches from the internal pudendal arteries, which come from the internal iliac arteries. The internal rectal venous plexus also drains the lower part of the anal canal. However, instead of traveling to the portal venous system, it drains into the systemic venous system. The internal venous plexus below the pectinate line drains into the inferior rectal veins, and then to the internal pudendal vein, and then into the internal iliac vein. The lymphatic vessels below the pectinate line drain to the superficial inguinal lymph nodes. The lower part of the anal canal is innervated by branches from the pudendal nerves, the inferior rectal nerves. These nerves control the contraction and relaxation of the external anal sphincter. Finally, the afferent fibers from the lower part of the anal canal are somatic, making the lower part sensitive to pain, touch, and temperature. To help you remember the differences above and below the pectinate line, everything above gets VIP access. Unfortunately, we don't live in a perfect world, so there are a few cases where things aren't so straightforward. The first comes from the arterial supply. The middle rectal arteries anastomose with the superior and inferior rectal arteries, and supply blood both above and below the pectinate line. The middle rectal veins also anastomose with the superior and inferior rectal veins from the internal rectal plexus to drain the anal canal both above and below the pectinate line. The internal rectal venous plexus also receives arterial blood from the superior and middle rectal arteries through short vessels, forming arteriovenous anastomoses. This forms pouches around the anal rectal junction called anal cushions. Alright, as a quick recap, the gastrointestinal organs of the pelvis are the rectum and the anal canal, which form the last parts of the gastrointestinal tract. In males, the rectum lies behind the fundus of the urinary bladder, the seminal vesicles, the right and left ductus deferens, and the prostate gland. In females, the rectum lies behind the lower end of the uterus and the vagina. The rectum has 5 external flexures: the sacral, the anorectal, and the superior, inferior, and intermediate lateral flexures. Its 3 internal folds, the superior, middle, and inferior transverse rectal folds, correspond to the lateral flexures. The blood supply of the rectum comes from the superior, middle, and inferior rectal arteries. As for venous drainage, the superior rectal veins drain into the portal venous system, whereas the middle and inferior rectal veins drain into the systemic venous system. The anal canal begins at the anorectal junction and descends posterior-inferiorly, ending at the anus. The anal canal has internal and external sphincters, which are circular muscles that control defecation. The internal sphincter is an involuntary muscle that contracts to prevent the leakage of feces or gas, and relaxes as the rectal ampulla fills with feces. The external anal sphincter is a voluntary muscle that controls defecation. Inside the anal canal, there are the anal columns, and at their lower ends, there are the anal valves, which have a small space above them called the anal sinuses. Finally, the lower borders of the anal sinuses and valves form an irregular line called the pectinate line, which is a landmark that marks important anatomical changes. Above the pectinate line, arterial supply is ensured by the superior rectal artery, while venous blood drains into the portal venous system. Below the pectinate line, arterial supply comes from the inferior rectal arteries, while venous blood drains into the systemic venous system. However, the middle rectal arteries and veins also ensure vascularization both above and below the pectinate line.
The inguinal region, sometimes called the groin, is the lower part of the anterolateral abdominal wall. It's a small area of great importance, as it serves as a passageway for structures such as the spermatic cord, vessels, and nerves to enter or leave the abdominal cavity. The inguinal region is a compact space, located superior to the thigh, lateral to the pubic tubercle, and inferomedial to the anterior superior iliac spine. One important structure in this region is the inguinal ligament, which is a thick fibrous band formed by the inferior border of the external oblique aponeurosis. The inguinal ligament extends from the anterior superior iliac spine of the ilium to the pubic tubercle on the pubic bone. Medially, the inguinal ligament's attachment to the pubis is reinforced by a number of smaller fibrous extensions, including the lacunar ligament and the pectineal ligament. The lacunar ligament attaches along the superior pubic ramus, and some fibers continue along the pecten pubis as the pectineal ligament. The lacunar ligament forms the medial border of the subinguinal space located inferior to the inguinal ligament. Important structures that pass through this space include the psoas major and iliacus muscles, and also the femoral nerve, artery, and vein, and the lateral cutaneous nerve of the thigh. Now, the most important feature of the inguinal region is the inguinal canal, which is a passage that extends inferomedially through the anterolateral abdominal wall. To better understand the anatomy of this canal, let's look at how it develops. In genetically male individuals, the testes begin to develop in the extraperitoneal space of the posterior abdominal wall, and within the first few months, each testis descends into the pelvis, pulled by a structure called the gubernaculum, which attaches to the anterolateral abdominal wall and later to the developing scrotum. As the testis descends from the abdominal cavity into the scrotum, its vessels and nerves migrate with it. When the testis gets closer to the anterolateral abdominal wall, a peritoneal outpouching called the processus vaginalis forms and pulls the layers of the anterolateral abdominal wall with it into the developing scrotum. The testis then follows the processus vaginalis into the scrotum. In males, the inguinal canal contains the ilioinguinal nerve and the spermatic cord, which includes the genital branch of the genitofemoral nerve. In genetically female individuals, the development of the inguinal canal is slightly different. While the ovaries also begin their development in the abdomen, they only descend as far as the pelvis. Because of this, the inguinal canal is less developed compared to males and obviously doesn't contain a spermatic cord. However, the inguinal canal in females contains the ilioinguinal nerve, the genital branch of the genitofemoral nerve, and the round ligament of the uterus, which is a remnant of the gubernaculum that extends from each ovary to the labia majora. Alright, now the inguinal canal starts at the deep inguinal ring, which is an opening in the transversalis fascia and is located at the midpoint of the inguinal ligament, just lateral to the inferior epigastric vessels. The inguinal canal ends at the superficial inguinal ring, which is an opening in the external oblique aponeurosis. Structures passing through the inguinal canal enter through the deep inguinal ring, except the ilioinguinal nerve, which enters the canal distal to the ring, and they all exit through the superficial inguinal ring. Now, the inguinal canal has 4 boundaries, which include the anterior and posterior walls, the roof, and the floor. The anterior wall is made up of the external oblique aponeurosis, while the posterior wall is formed by the transversalis fascia and is reinforced medially by the conjoint tendon, which is the union of the transversus abdominis and internal oblique aponeuroses. The roof is formed by different elements along the canal. Laterally, the roof of the inguinal canal is formed by the transversalis fascia, centrally by musculoaponeurotic arches of the internal oblique and transversus abdominis, and medially by the medial crus of the external oblique aponeurosis. Finally, the floor of the inguinal canal consists primarily of the gutter formed by the inguinal ligament and is supported medially by the lacunar ligament. Alright, now feel free to pause the video and see if you can recall what structures pass through the inguinal canal in males. Alright, now let's have a look at the spermatic cord itself, which suspends each testis in the scrotum. Including its fascial coverings, the spermatic cord contains 12 structures, which can be put into 4 groups of 3. So we can use the 3-3-3-3 rule to help remember them. The first group is the fascial layers of the spermatic cord. From deep to superficial, the layers are the internal spermatic fascia derived from the transversalis fascia, the cremasteric fascia derived from the internal oblique muscle, and the external spermatic fascia derived from the aponeurosis and deep fascia of the external oblique muscle. Next up are the 3 arteries, namely the artery to vas deferens, the testicular artery, and the cremasteric artery. Then there are the 3 nerves, which are the genital branch of the genitofemoral nerve, sympathetic fibers, and visceral afferent fibers. Finally, there are 3 other structures: the pampiniform venous plexus, the vas deferens, and the testicular lymphatic vessels. Now let's briefly look at the cremasteric fascia and muscle. The cremasteric fascia contains fibers of the cremaster muscle, which is derived from the lower fascicles of the internal oblique muscle that arise from the inguinal ligament, and it extends inferiorly to form a covering of the spermatic cord and testis. The cremaster muscle is innervated by the genital branch of the genitofemoral nerve, and its contraction helps retract the testis, or draw it superiorly, to regulate its temperature for optimal sperm production. Let's have another pause and see if you can remember the contents of the spermatic cord. Now, let's make our way down to the scrotum, which is made up of 2 main layers, the skin and the dartos fascia. The dartos fascia is continuous anteriorly with the subcutaneous tissue of the abdomen called the scarpa fascia, and posteriorly with the subcutaneous tissue of the perineum or Colles fascia. Now, the dartos fascia contains smooth muscle, called the dartos muscle, and it's attached to the scrotal skin. So when the muscle contracts, the skin moves with it, causing the scrotum to wrinkle when it's cold. It also helps retract the testis. Both of these functions limit heat loss. The dartos muscle is innervated by sympathetic fibers of the genital branch of the genitofemoral nerve. Now let's look within the scrotum at the testes and their coverings. Each testis is partially covered by a layer of the peritoneal membrane called the tunica vaginalis, which is a serous membrane covering the testis. In fact, it's the embryological remnant of the processus vaginalis. The visceral layer of the tunica vaginalis covers the testis, except for the part where the testis is attached to the epididymis and spermatic cord. The visceral layer of the tunica vaginalis continues as the parietal layer, which lies adjacent to the internal spermatic fascia. On their outer part, the testes have a tough fibrous capsule called the tunica albuginea, which is made up of dense connective fibrous tissue that continues inside the testes, creating septa that divide them into lobules. These lobules contain the coiled seminiferous tubules, which is where sperm are produced. The sperm travel from the seminiferous tubules into the straight tubules and then into the rete testis, which is a network of collecting canals. From here, the sperm move to the epididymis through efferent ductules. The epididymis has three parts: the head, where the efferent ductules merge, the body, and the tail, which continues as the vas deferens. Each one of the two testes is supplied by a testicular artery, which is a direct branch of the abdominal aorta, emerging just inferior to the renal artery. Their venous drainage is through a network of veins called the pampiniform plexus, which drains into the right or left testicular vein. The right testicular vein drains into the inferior vena cava directly, whereas the left testicular vein drains into the left renal vein. The lymphatic drainage of the testes is to the pre-aortic and lateral aortic lymph nodes. In contrast, the scrotum's lymphatic drainage is to the nearby superficial inguinal lymph nodes. Remember, the testes develop in the abdomen and eventually descend, so it makes sense their lymphatic drainage is to lymph nodes in the abdomen, not to the inguinal lymph nodes. Alright, as a quick recap, the inguinal ligament extends from the anterior superior iliac spine of the ilium to the pubic tubercle on the pubic bone. The inguinal canal has a deep ring, located just lateral to the inferior epigastric artery, and a superficial ring. The inguinal canal has four boundaries, which are the anterior wall consisting of the external oblique aponeurosis, the posterior wall consisting of the transversalis fascia, the roof formed by the internal oblique and transversus abdominis muscles, and finally the floor, which consists of the inguinal and lacunar ligaments. In both genetically male and female individuals, the inguinal canal transmits the ilioinguinal nerve and genital branch of the genitofemoral nerve. In males, the inguinal canal also transmits the spermatic cord, while in females it contains the round ligament of the uterus. The male's spermatic cord consists of three layers, which are internal spermatic fascia, the cremasteric fascia, and the external spermatic fascia. It carries three arteries, which are the artery to vas deferens, the testicular artery, and the cremasteric artery, three nerves, namely the genital branch of the genitofemoral nerve, sympathetic fibers, and visceral afferent fibers, and finally three other structures, which are the pampiniform venous plexus, the vas deferens, and the testicular lymphatics. The testes reside in the scrotum and are directly covered by the visceral layer of the tunica vaginalis, which is continuous with the parietal layer of the tunica vaginalis. They are supplied by testicular arteries, which are direct branches of the abdominal aorta. Their venous drainage is through the pampiniform plexuses, while the lymphatic drainage is to the pre-aortic and lateral aortic lymph nodes. The posterior abdominal wall is a complex area of the body made up of muscles, vessels, and nerves that work together to hold abdominal organs in place, adjust our posture, stabilize the hip joint, and even flex our thighs on leg day. The main paired muscles of the posterior abdominal wall include psoas major, iliacus, and quadratus lumborum, and naturally, for those muscles to work properly, they receive innervation from various nerves. Okay, now let's take a closer look at these muscles. First up is the psoas major, which is a long, thick muscle that lies lateral to the lumbar vertebrae. It originates superiorly on the transverse processes of the bodies and adjacent intervertebral discs of the T12 through L5 vertebrae. The psoas major passes inferolaterally, deep to the inguinal ligament in order to insert on the lesser trochanter of the femur. Finally, approximately half the population has a psoas minor muscle that sits on the anterior aspect of each psoas major muscle. Now, the psoas major muscle is covered by the psoas fascia or the psoas sheath, which is attached medially to the lumbar vertebrae and pelvic brim. The psoas sheath is thickened superiorly, forming the medial arcuate ligament. Inferior to the iliac crest, the psoas fascia is continuous with the part of the iliac fascia that covers the iliacus muscle. When acting inferiorly with the iliacus muscle, the psoas muscle flexes and laterally rotates the thigh, and when it acts superiorly, it causes lateral flexion of the vertebral column. When sitting, the psoas muscle acts with the iliacus muscle to flex the trunk. The innervation of the psoas major muscle comes from the anterior rami of the L1, L2, and L3 spinal nerves. Next is the iliacus muscle, which is a large triangular muscle that lies lateral to the inferior portion of the psoas major muscle. It originates superiorly on the superior 2/3 of the iliac fossa, ala of sacrum, and anterior sacroiliac ligaments. It also inserts at the lesser trochanter of the femur. In fact, most of its fibers join the tendon of the psoas major muscle to form the iliopsoas muscle, which is the main flexor of the thigh and a stabilizer of the hip joint, and it also helps maintain erect posture. The innervation of iliacus comes from the femoral nerve, which is derived from the anterior rami of spinal nerves L2 through L4. Now let's look at the quadratus lumborum muscle, which forms a thick muscular sheet in the posterior abdominal wall along the transverse processes of the lumbar vertebrae. It originates inferiorly on the iliac crest and iliolumbar ligament and inserts superiorly on the medial half of the inferior border of the 12th rib and the tips of the lumbar transverse processes. The quadratus lumborum muscle is enclosed within 2 layers of the thoracolumbar fascia. The anterior layer of the thoracolumbar fascia, also called the quadratus lumborum fascia, thickens in the superior aspect to form the lateral arcuate ligament. Bilaterally, the quadratus lumborum muscles extend the trunk and also fix the 12th pair of ribs during inspiration. Unilaterally, it causes lateral flexion of the vertebral column. Its innervation comes from the subcostal nerve and anterior rami of the L1 to L4 nerves. So far, so good. Time for a quick quiz. What are the main actions of the composite iliopsoas muscle and the quadratus lumborum muscle? Now let's have a quick look at the nerves of the posterior abdominal wall, which provide somatic innervation through the subcostal nerves and the lumbar plexus, and autonomic innervation through the sympathetic trunks and associated ganglia. First up, the subcostal nerves are paired nerves that represent the anterior rami of T12. They arise in the thorax and pass posterior to the lateral arcuate ligaments into the abdomen. Then they run inferolaterally on the anterior surface of the quadratus lumborum to eventually pass through the transversus abdominis, internal oblique, and external oblique muscles, innervating them and the skin of the anterolateral abdominal wall. Next up is the lumbar plexus, which forms within the psoas major muscle. This is a network of nerves that is composed of the anterior rami of the L1 through L4 spinal nerves. The nerves that arise from the lumbar plexus include the iliohypogastric nerve, the ilioinguinal nerve, the genitofemoral nerve, the lateral cutaneous nerve of the thigh, the femoral nerve, the obturator nerve, and finally the lumbosacral trunk. First, let's look at the ilioinguinal and the iliohypogastric nerves, both of which arise from the anterior ramus of L1. They enter the abdomen posterior to the medial arcuate ligament and then pass inferolaterally, anterior to the quadratus lumborum. Then they run superior and parallel to the iliac crest, with the iliohypogastric nerve traveling more superiorly than the ilioinguinal nerve. Then they pierce the transversus abdominis and internal oblique muscles near the anterior superior iliac spine, supplying them with motor innervation. Finally, they pass through the external oblique muscle in order to supply this muscle and the skin of the inguinal and pubic regions. Next up is the genitofemoral nerve, which arises from the anterior rami of L1 and L2. It travels within the psoas major and eventually pierces through it to run inferiorly on its anterior surface. Lateral to the common and external iliac arteries, it divides into femoral and genital branches. The femoral branch of the genitofemoral nerve provides sensation to the skin of the upper anterior thigh. The genital branch of the genitofemoral nerve supplies motor innervation to the cremaster muscle and sensation to the scrotal skin in males and the skin of mons pubis and labia majora in females. Next is the lateral cutaneous nerve of the thigh, also called the lateral femoral cutaneous nerve, which arises from the anterior rami of L2 and L3. This nerve runs inferolaterally on the iliacus muscle and enters the thigh deep to the inguinal ligament, medial to the anterior superior iliac spine. Its role is to provide sensation to the skin on the anterolateral surface of the thigh. Moving on, next is the femoral nerve, which arises from the anterior rami of L2 through L4. It emerges from the lateral border of the psoas major muscle, gives motor innervation to the iliacus muscle, and then it passes deep to the inguinal ligament into the anterior thigh. In the thigh, it gives motor innervation to the flexors of the hip and extensors of the knee, and gives rise to cutaneous branches that provide sensation to the anteromedial thigh and the medial leg and foot. Next up is the obturator nerve, which also arises from the anterior rami of L2 through L4 and emerges from the medial border of the psoas major muscle. It passes into the lesser pelvis and then through the obturator foramen to enter the medial thigh, where it gives motor innervation to the obturator externus and adductor muscles and sensation to the medial thigh. Now, in about 10% of people, there's an accessory obturator nerve, which arises from the anterior rami of L3 and L4. It parallels the medial border of the psoas major muscle, anterior to the obturator nerve, and crosses superior to the superior pubic ramus in close proximity with the femoral vein. Finally, the lumbosacral trunk, which is formed from the anterior rami of L4 and L5, passes over the ala of the sacrum and runs inferiorly into the pelvis to contribute to the formation of the sacral plexus, along with the anterior rami of the S1 through S4 nerves. And last but not least, there's the abdominal portion of the sympathetic trunk. There are typically 4 lumbar paravertebral sympathetic ganglia and the interganglionic branches that connect them. They are continuous with the thoracic portion of the sympathetic trunk deep to the medial arcuate ligaments of the diaphragm. Now, the abdominal sympathetic trunk descends on the anterolateral aspects of the bodies of the lumbar vertebrae, just adjacent to the psoas major muscle. Inferiorly, they cross the sacral promontory and then continue down into the pelvis as the sacral portion of the sympathetic trunk. Alright, as a quick recap, the psoas major muscle originates from the T12 to L5 vertebrae and intervening intervertebral discs and inserts on the lesser trochanter of the femur. The iliacus muscle originates on the iliac fossa and inserts on the psoas major tendon and lesser trochanter of the femur. The iliacus muscle and the psoas muscle form the iliopsoas muscle, which is the main hip flexor. The quadratus lumborum originates on the iliac crest and inserts on the lumbar transverse processes and inferior border of the 12th rib. It extends and laterally flexes the vertebral column and fixes the 12th rib during inspiration. The subcostal nerve arises in the thorax, and its main role is to supply the anterolateral abdominal wall muscles and a portion of the skin of the anterolateral abdominal wall. The lumbar plexus is a network of nerves that's composed of the anterior rami of L1 through L4. Its branches include the iliohypogastric nerve and the ilioinguinal nerve, the genitofemoral nerve, the lateral cutaneous nerve of the thigh, the femoral nerve, the obturator nerve, and sometimes an accessory obturator nerve, and finally the lumbosacral trunk. Lastly are the abdominal and sacral portions of the sympathetic trunk. At first glance, the peritoneum and peritoneal cavity seem pretty simple, but some aspects, like the peritoneal ligaments, can be a bit confusing. In order to understand them, we need to go way back to their embryological formation. Once upon a time, in an amniotic galaxy far, far away, the embryonic body cavity is lined with mesoderm. As the fetus is developing, the embryonic body cavity becomes the primordial abdominal cavity, and the mesoderm lining it becomes the parietal peritoneum, which is a transparent, serous membrane that helps to form a closed sac called the peritoneal cavity. As abdominal organs develop, they protrude into the peritoneum like pushing your fist into a balloon. Your fist represents the developing abdominal viscera, and the balloon represents the parietal peritoneum. As your fist pushes into the balloon, it is lined closely by part of the balloon, and this represents the visceral peritoneum. So, the visceral peritoneum covers the viscera, while parietal peritoneum lines the internal surface of the abdominopelvic wall, and these two layers are continuous with one another. The parietal peritoneum has the same blood and lymphatic supply and the same nerve supply as the region of the wall it lines, meaning it is sensitive to pressure, pain, heat, and cold. The visceral peritoneum, on the other hand, has the same blood, lymphatic, and nerve supply as the viscera it covers, meaning it is sensitive to stretch and chemical irritation. Depending on their relationship with the peritoneum, abdominal and pelvic organs can be either intraperitoneal, retroperitoneal, or subperitoneal. Intraperitoneal organs are almost completely covered with visceral peritoneum, but remember they're not inside the peritoneal cavity. These organs include the stomach, first part of the duodenum, jejunum, ileum, transverse colon, sigmoid colon, liver, and spleen. Now, the retroperitoneal organs, also known as primarily retroperitoneal, develop posterior to the peritoneal cavity, outside of the peritoneum, so they're only partially covered with peritoneum. The retroperitoneal organs include the kidneys, ureters, suprarenal glands, and rectum. There are also secondarily retroperitoneal organs, where they begin as intraperitoneal but later on in development become attached to the posterior abdominal wall. The secondarily retroperitoneal organs include the second to the fourth part of the duodenum, pancreas, and the ascending and descending colon. Lastly, the subperitoneal organs, like the urinary bladder, are similar to the retroperitoneal organs, except they are located inferior to the peritoneal cavity rather than posterior to it. The peritoneal cavity is a potential space between the parietal and visceral layers of the peritoneum. Keep in mind that the peritoneal cavity has no abdominal organs. It only contains a thin film of fluid that contains water, electrolytes, and other substances derived from the interstitial fluid. The peritoneal fluid helps viscera move without friction, allowing for peristalsis, and it also has white blood cells and antibodies to resist infection. Quick quiz. Can you remember which organs are retroperitoneal and which organs are intraperitoneal? Now we are going to look at some of the peritoneal structures in adults. Let's first start by looking at the omentum, which is a fold of peritoneum. There's actually two of them, the greater omentum and the lesser omentum. The greater omentum is a 4-layered peritoneal fold that hangs like an apron from the greater curvature of the stomach and the proximal part of the duodenum. After descending, it folds back and it attaches to the anterior surface of the transverse colon and its mesentery. These 4 layers fuse with one another. The lesser omentum is a double-layered peritoneal fold that connects the lesser curvature of the stomach and the proximal part of the duodenum to the liver. Posterior to the lesser omentum, there's a space known as the lesser sac or omental bursa, and the rest of the peritoneal cavity is known as the greater sac. These two spaces communicate through the omental foramen, also called the epiploic foramen. Anterior to the omental foramen, there's the hepatoduodenal ligament, which is the free edge of the lesser omentum that contains the portal triad. Posterior to the omental foramen is the inferior vena cava and the right crus of the diaphragm. Superior to the omental foramen is the liver, and inferior to the omental foramen is the first part of the duodenum. The peritoneal cavity as a whole is divided by the transverse mesocolon into a supracolic compartment and an infracolic compartment. The supracolic compartment contains the stomach, liver, and spleen. The infracolic compartment is located posterior to the greater omentum and contains the small intestine, as well as the ascending and descending colon. Communication between the supracolic and infracolic compartments happens through the pericolic gutters, which are grooves between the lateral aspect of the ascending or descending colon and the posterolateral abdominal wall. Now let's talk about the mesenteries within the abdomen. Remember that a mesentery is a double layer of peritoneum that occurs as a result of the developing abdominal organs and is continuous with the parietal and visceral layers of peritoneum. The aorta, inferior vena cava, and the nerves and lymphatics are all posterior to the peritoneum, so the mesenteries allow for passage of neurovasculature from the body wall to and from their respective organs. The largest mesentery in the body is the mesentery of the small intestine, which is usually just called the mesentery, and connects the posterior abdominal wall to the jejunum and ileum. Next is the transverse mesocolon, which connects the transverse colon to the posterior abdominal wall. Then there's the sigmoid mesocolon, which connects the sigmoid colon to the posterior wall of the abdomen and pelvis. Finally, there's the mesoappendix, which connects the ileum to the appendix. Time for a quick break. How can the peritoneal cavity be divided? Now let's switch gears and explore the development to understand how these structures came to be. Let's first look at the embryologic mesenteries. Now, the gastrointestinal tract begins as a tube, known as the gut tube. Initially, it is closely associated with the posterior abdominal wall, but begins to move farther away from it. The gut tube is then suspended from the dorsal wall of the embryo by connective tissue known as the dorsal mesentery, and from the ventral wall by the ventral mesentery. The ventral mesentery is derived from a plate of mesoderm known as the septum transversum and extends from the ventral aspect of the proximal part of the duodenum to the developing liver. The dorsal mesentery extends from the lower portion of the esophagus to the rectum, attaching it to the posterior body wall and creating a pathway for blood vessels, nerves, and lymphatics. The abdominal organs then continue to get larger as the fetus grows, which causes the gut to rotate. The dorsal and ventral mesenteries rotate along with the organs they are attached to and eventually reach their final destinations. Let's look at the ventral mesentery and how it forms. As the liver develops, it protrudes within the ventral mesentery and forms an anterior part, called the falciform ligament, and a posterior part, called the lesser omentum. Now, the free edge of the falciform ligament contains the umbilical vein, which closes off after birth and remains as the round ligament of the liver. The lesser omentum is actually made of two ligaments called the hepatoduodenal ligament and the hepatogastric ligament. The hepatoduodenal ligament contains the vessels coming to and from the liver, known as the portal triad, and extends from the proximal part of the duodenum to the liver. The hepatogastric ligament is the rest of the lesser omentum, connecting from the liver to the lesser curvature of the stomach. The liver is completely surrounded by ventral mesentery, except on its superior surface, where it is in direct contact with the inferior surface of the diaphragm, and this is called the bare area of the liver. Then there are the coronary ligaments, which are the peritoneum reflection from the inferior surface of the diaphragm. Now that we've covered the ventral mesentery, let's see how the embryonic dorsal mesentery gives rise to adult structures. Due to the rotation of the stomach and the growing pancreas, the duodenum moves from the midline to the right side of the peritoneal cavity. This pushes the duodenum and pancreatic head against the dorsal body wall, where the right surface of the dorsal mesoduodenum fuses with the posterior abdominal wall peritoneum, making these two organs secondarily retroperitoneal. However, a small part of the proximal duodenum does remain intraperitoneal, which is the part attached to the stomach. Similarly, the ascending and descending colon will be pushed to either side to push against the posterior abdominal wall, where their mesenteries will also fuse with the peritoneum. However, the appendix and inferior end of the cecum retain a free mesentery. The dorsal mesentery also remains attached to the stomach, known as the dorsal mesogastrium, which continues to grow as the stomach is twisting and bulges out, forming the four-layered apron known as the greater omentum. The dorsal mesentery of the jejunum and ileum is the mesentery proper. Finally, the dorsal mesentery also gives rise to the gastrosplenic and splenorenal ligaments, which arise similarly to the falciform ligament and the lesser omentum. The spleen develops within the dorsal mesentery, posterior to the primitive gut tube, creating the gastrosplenic ligament between the spleen and the stomach, and the splenorenal ligament between the spleen and the left kidney. These ligaments allow for the passage of blood vessels, nerves, and lymphatics to and from these organs. There is also the gastrophrenic ligament, which connects the stomach to the diaphragm, and the phrenicocholic ligament, which is located at the left colic flexure and attaches to the diaphragm. Alright, as a quick recap, the parietal peritoneum lines the internal surface of the abdominopelvic wall, while the visceral peritoneum covers the viscera. Intraperitoneal organs include the stomach, first part of the duodenum, jejunum, ileum, transverse colon, sigmoid colon, liver, and spleen. Retroperitoneal organs include the kidneys, the ureters, the suprarenal glands, and the rectum. Secondarily retroperitoneal organs include the second to the fourth part of the duodenum, the pancreas, the ascending colon, and descending colon. The peritoneal cavity contains no abdominal organs and has peritoneal fluid to help viscera move without friction. The peritoneal cavity is divided into the greater sac and the lesser sac, which communicate through the omental foramen. The peritoneal cavity is divided by the transverse mesocolon into a supracolic compartment and an infracolic compartment. The mesenteries within the abdomen connect the viscera to the posterior abdominal wall. These include the mesentery of the small intestine, the transverse mesocolon, the sigmoid mesocolon, and the mesoappendix. The ligaments that derive from the embryological ventral mesentery are the falciform ligament, the coronary ligaments, the hepatogastric ligament, and the hepatoduodenal ligament. The ligaments that derive from the embryological dorsal mesentery include the gastrophrenic ligament, the gastrosplenic ligament, the phrenicocholic ligament, the transverse mesocolon, and the greater omentum.
The major vessels of the abdomen, including the abdominal aorta and the inferior vena cava, course along the posterior abdominal wall. Branches and tributaries of these vessels help supply and drain the posterior abdominal wall and the abdominal viscera. Important lymphatic vessels that help with drainage of the lower body are also found in this area. Let's start off with the abdominal aorta, which gives rise to most of the arteries supplying the posterior abdominal wall. It transitions from the thoracic aorta to the abdominal aorta, starting at the aortic hiatus, located within the diaphragm, at the level of the T12 vertebra. Then it descends anterior to the vertebral bodies and ends at the level of the L4 vertebra. From superior to inferior, the abdominal aorta has a number of structures associated with it anteriorly. These include the celiac plexus and ganglia, the body of the pancreas, the splenic vein, the left renal vein, the horizontal part of the duodenum, and the coils of the small intestine. Structures to the right of the abdominal aorta include the inferior vena cava, azygous vein, cisterna chyli, and the thoracic duct. Posteriorly, the left lumbar veins pass behind the aorta to reach the inferior vena cava. Now, let's talk about the various branches that arise from the abdominal aorta. These can be organized in three categories, based on the vascular plane or direction in which the arteries branch from the abdominal aorta. First, there are paired visceral branches that travel in the lateral plane. Second, there are paired parietal branches, which travel in the posterolateral plane. And third, there are the unpaired visceral branches in the anterior midline plane. The paired visceral branches include the middle suprarenal arteries, the renal arteries, and the gonadal arteries, which supply the suprarenal glands, kidneys, and the testicles or ovaries based on the biological sex. Next up are the paired parietal branches, which include the inferior phrenic arteries and the lumbar arteries, which supply the inferior surface of the diaphragm and posterior abdominal wall. The subcostal arteries are paired parietal branches of the thoracic aorta, but they emerge below the diaphragm to supply the posterior abdominal wall. Finally, the unpaired visceral branches include the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery, which supply the foregut, midgut, and hindgut structures respectively. The abdominal aorta terminates at the level of the L4 vertebra, where it bifurcates into the right and left common iliac arteries. The two arteries diverge and run inferolaterally following the medial border of the psoas muscles to the pelvic brim. At this point, each common iliac artery divides into an external iliac artery and internal iliac artery. The external iliac arteries follow the iliopsoas muscle. Before leaving the abdomen, the external iliac arteries give rise to the inferior epigastric arteries and deep circumflex iliac arteries, which supply the anterolateral abdominal wall. The internal iliac artery passes medially over the pelvic brim and descends into the pelvic cavity to supply various structures of the pelvis. Time for a quick quiz. Let's see if you can remember the unpaired and paired visceral branches of the abdominal aorta. Great. Let's talk about the venous drainage of the posterior abdominal wall, which are mainly tributaries of the inferior vena cava. The inferior vena cava begins anterior to the L5 vertebra through the union of the common iliac veins, just right of the median plane, inferior to the aortic bifurcation, and posterior to the proximal part of the right common iliac artery. The inferior vena cava then travels superiorly on the right side of the bodies of the L3 through L5 vertebrae, and just to the right of the abdominal aorta. Finally, the inferior vena cava leaves the abdomen by passing through the caval opening in the diaphragm at the level of the T8 vertebra. The veins that correspond to the unpaired visceral branches are tributaries of the hepatic portal vein, which send blood from the abdominal viscera to the liver first for metabolic processing and detoxification. Then, this blood leaves the liver through the hepatic veins, which then drain into the inferior vena cava. Now, the veins that correspond to the paired visceral branches of the aorta include the right suprarenal vein, the right renal vein and left renal vein, and the right gonadal vein. Remember that the left suprarenal vein and gonadal vein drain directly to the left renal vein and then go to the inferior vena cava, while the right suprarenal vein, the right renal vein, and the right gonadal vein all drain directly to the inferior vena cava. Finally, the tributaries of the inferior vena cava that correspond to the paired parietal branches of the aorta include the inferior phrenic veins and the third and fourth lumbar veins. Let's take a quick break and see if you can remember the level at which the inferior vena cava begins. Finally, let's discuss the lymphatics of the posterior abdominal wall, which lie along the aorta, the inferior vena cava, and the iliac vessels. The common iliac lymph nodes receive lymph from the external and internal iliac lymph nodes. Then, lymph from the common iliac lymph nodes passes to the right and left lumbar lymph nodes, which lie on both sides of the inferior vena cava and aorta. The right and left lumbar lymph nodes, which can also be classified as caval or aortic lymph nodes, receive lymph directly from the posterior abdominal wall, kidneys, ureters, testes or ovaries, uterus, and uterine tubes. The inferior mesenteric and common iliac lymph nodes, which drain the descending colon, pelvis, and lower limbs, also send lymph to the right and left lumbar lymph nodes. Lymph from the digestive tract, liver, spleen, and pancreas pass along the celiac and superior and inferior mesenteric arteries to the pre-aortic lymph nodes, which are known more specifically as the celiac and superior and inferior mesenteric nodes. The efferent lymphatic vessels from these lymph nodes give rise to lymphatic trunks, which eventually join to form the inferior end of the thoracic duct, which is situated anterior to the bodies of the L1 and L2 vertebrae, specifically between the right crus of the diaphragm and the aorta. Sometimes where the thoracic duct begins can look like a thin-walled dilated sac called the cisterna chyli, which varies in size and shape. The lymph from the lower half of the body drains into the cisterna chyli, where all the main lymphatic trunks converge together. The thoracic duct then travels superiorly through the aortic hiatus in the diaphragm and into the posterior mediastinum, where it collects more lymph from the left upper quadrant of the body. Finally, the thoracic duct ends by entering the venous system at the junction of the left subclavian and internal jugular veins. Okay, let's see if you can remember the lymph node groups that lie within the posterior abdominal wall. All right, as a quick recap, the abdominal aorta begins at the aortic hiatus, at the level of the T12 vertebra, and ends at the level of the L4 vertebra, bifurcating into the left and right common iliac arteries. The paired visceral branches of the abdominal aorta are the middle suprarenal arteries, the renal arteries, and the gonadal arteries. The paired parietal branches of the abdominal aorta are the inferior phrenic arteries and the lumbar arteries. The subcostal arteries are paired parietal branches of the thoracic aorta, but they emerge below the diaphragm to supply the posterior abdominal wall. The unpaired visceral branches of the abdominal aorta are the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. The tributaries of the inferior vena cava correspond to the paired visceral and parietal branches of the abdominal aorta. The left suprarenal vein and gonadal vein drain directly into the left renal vein, and then to the inferior vena cava. The veins corresponding to the unpaired visceral arteries are tributaries of the hepatic portal vein. Lymphatic vessels and lymph nodes in the abdomen lie along the aorta, the inferior vena cava, and iliac vessels. Lymph from the common iliac lymph nodes passes to the right and left lumbar lymph nodes. Lymph from the digestive tract, liver, spleen, and pancreas drains into the pre-aortic lymph nodes, known specifically as the celiac and the superior and inferior mesenteric nodes. Lymphatic trunks from all of the nodes in the abdomen converge to form the beginning of the thoracic duct, which sometimes looks like a dilated sac called the cisterna chyli.